So you talked a little bit about finding the right balance at the end of the presentation. I'm curious as to what the process was for determining the right balance of I think it was inflationary increases versus the process and outcome payments.
Yeah.
What that process was and how you arrived at figure.
So it's a great question. I'm going to answer it kind of on two tracks. So one is, how do we at Blue Cross negotiate contracts with each provider we negotiate with? And I think the answer to that is, it's a negotiation. And we start in one place that's probably less aggressive or more aggressive in terms of saving money than where they start, and we generally meet somewhere in the middle. And then we have a pretty prescribed, we have a philosophy associated with the alternative quality contract about what portion of the payments really needs to be tied to quality, where we negotiate probably a little bit less. And what I'd say is, if you look at the average rate of healthcare inflation over the last, decade, it's probably on average about 6% in Massachusetts, 6 to 7%. We are negotiating much more. Back again, we have a real responsibility as a steward, and trying to deliver good prices and keep premium prices down for our members. We are now negotiating successfully much more aggressive contracts than that with the providers that we're negotiating with, and much closer to the growth rate in the economy, which is right now about 2.6%. But what I was alluding to on striking the right balance really alludes to the debate that's going on in Massachusetts, where there is now a statewide, it doesn't apply to any of these rates that I've been talking about, but a statewide goal to not have per person health spending grow any faster than the growth rate in the state product, which is 2.6%. And there aren't that many, there aren't huge teeth in that law, but they're going to be measuring progress against that goal every year, this new Health Policy Commission, both for us and at the plan level, at the hospital level, at the physician group level, and they can call people in if they miss that target and make us present plans for how we're going to hit it, and potentially fine up to $500,000 providers who miss it. So they're really sort of operating at both those levels in Massachusetts right now.
Actually, I just wanted to quickly follow up. So in the ACQ, the early results, AQC, sorry, you're seeing cost reductions of 2%, 3%. I mean, given what Massachusetts spends already per capita, you're talking about a reduction of $90 to $300 off that $9,000 per patient.
Yeah.
Modest.
Yeah.
Doesn't really cut into the fact that it's still an incredibly high amount to be spending on patients. So how far do you think this approach can really get into not only keeping costs capped at inflation, but actually starting to cut into, because the reality is you can probably keep improving quality if you just keep spending money. So, what does Blue Cross think about actually trying to really cut into, decreases of 5%, 10%, 15%?
So I'll start, and then I'd love Gary's perspective on this nationally. But I'd say, first of all, the level of change that needs to happen within the delivery system is hard. It's really challenging to change the way you practice. And so, I think we've headed into this. Some people believe the amount of waste in our healthcare system. So when you look at that per person spending amount, some people believe that 30% of that, Don Berwick, who's now running for governor and ran the Center for Medicare and Medicaid Services, is regularly quoted saying he believes that about 30% of the state's spending is unnecessary or wasted. Some of that's administrative costs, some of that's just things that we could avoid, hospitalizations we could avoid. But getting that out of the system is going to be slow because there aren't any silver bullets, and because we've already done it. So I think we have to be thoughtful about it, and we're being I'd say we're really negotiating in a much more aggressive stance than we ever have before. But it's gonna take a while to transform the system. And some people don't think that it's changing fast enough. And I think that also gets into the public policy debate about, do we need a stronger role for government in pushing, and there are conversations happening about, should we have government set prices now? Should we go back to rate setting systems? We deregulated 20 years ago, and some people in this last legislative debate said, was that the right decision? So, what are your thoughts on this?
I agree completely. I think that Tim's raising a good point about the fact that again there's a lot of concern that what we're doing is going to lead to maybe some modest improvements, but it's not going to really fundamentally alter sort of the cost trajectory in this country and to really improve quality in a very, very significant manner. I think that we do need to create payment approaches that will dramatically alter the way in which providers provide care. I think we need to make a dramatic shift to what people are referring to as population health. We need to really focusing on creating incentives, creating payment approaches whereby providers are really focusing on keeping people healthy. But of course, we may think about that as a dramatic shift, and it actually would be underestimating it. Think about hospitals and all the beds that they have. I mean, hospitals are in business to fill those beds, and getting hospital executives to think about tremendously downsizing those facilities and focusing on, and the difference is for hospital executives, they make money when people cross that threshold and come into their building. How do we get them to start thinking about, we make money when people don't come into our building? Okay, that's a dramatic shift in mindset, and it's going to take a while before we can get there. That's really where we want to go to really respond to Tim's point about, well, okay, how are we going to dramatically, reduce the rate of cost growth in this country and dramatically improve quality of care without just throwing a lot of money at it.
And I'd say, I've been thinking about just picking up on the hospital example, so just to further illustrate the complexity. You've got, incredible concerns by labor. And so those hospitals have beds, they have staffed beds. And so, there are a lot of people who, I'll just use Massachusetts as an example. When we were having this healthcare cost debate in the legislature, you had a lot of hospitals expressing concern about, look, we're the economic engine of this state. We're just emerging from a recession. Don't do anything to jeopardize this gigantic sector, the health of this gigantic sector of our economy. So you've got all of these, and then you've got, labor unions that are very, very organized in terms of hospitals. So there's a lot of interest really vested in the status quo. And so changing that and redeploying that part of the workforce and getting all those buildings and those costs out of the system. I mean, we may decide that we don't need as many hospitals as we have. Or what community is going to be the one to say, oh, sure, close mine, as we do successfully keep people, out of the hospital. It's tough.
And also, Massachusetts does have the highest per capita cost in the country, but it's also actually a bellwether in terms of some of the initiatives that are going on here, like Blue Cross Blue Shield. Things look very different in North Dakota. And so what we're seeing here in Massachusetts is not by any means what we're seeing in many other parts of the country. And so while we hopefully will see some dramatic improvements in this state, that doesn't mean that the rest of the country will be following anytime soon.
Well, first of all, thank you for two incredibly interesting presentations, which triggers in my mind two questions. One is, I wondered whether you think that the financial benefits to healthcare providers of providing more efficient service will, in the long term, because of competitive pressures, turn out to be merely temporary. Because, on the one hand, the payers, the insurance companies, or the government, will find themselves under pressure to reduce the payments to providers if the provider's cost structure now has been lowered, as occurs in other industries. And second, even if that were not to happen, the providers themselves, or at least some of the providers, would lower the prices that they demand in an effort to gain market share. And so their peers would have to match those prices. Second question, if, as you point out...
I might have to ask the second one after, because my brain isn't that big to
Okay.
keep track of all the elements of the first one. Do you mind?
Okay. Go ahead.
maybe taking the second part of the first question, I'll just give you an example on this issue of price lowering. So I'll give you a local example. So Harvard-Vanguard Healthcare, which is under the Atrius Healthcare umbrella, largest independent physician network in Massachusetts, was one of the early signer on to our AQC. And they quickly, by virtue of the data that we were giving them, took a look at where they were, because they're responsible for managing all of the care and costs of their patient population, took a look at who their partner hospital was, where they referred their patients for surgeries and other things, and pretty quickly discovered that actually they could get a better value from a different hospital relationship. And they changed their referring hospital because they found by moving their patients from Brigham to BI, they were getting equally good quality, but BI was cheaper. So there is absolutely an incentive and a competitive incentive there, exactly as you described, but frankly, it's what we want to see. We want to create a level of healthy competition in the market. On the first part of your question around, and I'd love to hear if you're seeing this in other places, on the first part of your question that relates to margins, I'd say when you think about who the purchasers are, we're buying healthcare, but we're buying it on behalf of individuals and employers. And, they do, to the extent the system becomes more efficient, want some of those savings. In Massachusetts, we're very lucky. This market is dominated by not-for-profit health plans. We spend about 10% of premiums on average on administrative costs here. Nationally, the health plans were kind of loud about having to get closer to, 80, and the number of waivers that CMS granted in the implementation of the Affordable Care Act for people who said they couldn't quite get there yet is pretty high. And so we operate on razor-thin margins ourselves as a nonprofit health plan, and frankly are pretty comfortable with a 1% margin. It gives us enough to invest in systems improvements we need to make ourselves, but we want to give that money. We want to give that money to our members and to employers and offer the best value we can. And so my own personal belief is I kind of hope that's how most of the healthcare system will operate. I'm not, a total Pollyanna, so I know that isn't the case. But, I think, frankly, one feature of the ACA was telling other health plans in the country to behave more like us. So that's my comment.
And I agree. What I would say, though, also is that I would hope that as we move forward, I certainly think that some of your comment is correct in the sense of sort of the competitive dynamics that may take hold. But at the same time, again, I would think that, hope anyways, that as we move toward this paradigm of value, okay, that it won't only be who is providing care at the lowest price, that in fact will become more sophisticated, and we can begin to think about, just as we buy a car, right? We think about value. We don't always go for the lowest price car. We think about what's that cost-quality trade-off. In some cases, providers who charge more may be worth it, okay, because they're providing higher value. Right now, we really don't know much about it. And a lot of providers that are perceived to be highest quality, we're finding out, well, actually, maybe your quality isn't any better than your competitor, or maybe not even as good. Okay? And as we're becoming more sophisticated about that, my hope is that we will be able to really shop on the basis of value. And that doesn't always mean that we're going to go to the lowest provider, the lowest price provider. I think that we'll become more sophisticated and we'll be able to begin to really focus on value in terms of how we select our healthcare providers.
Yeah, note that Atrius example I gave you was equal quality and lower cost, and thus higher value.
Thank you for those comments. So let me throw out the second question. Given, as you say, the importance of other entities outside of the health provider system in determining the population's healthiness, and perhaps greater importance than the health care system, why not use this pay-for-performance idea to pay individuals and communities for things, in the case of individuals, for controlling their weight, for not drinking or excessively or not smoking. In the case of communities, pay communities who do better in terms of providing affordable housing, recreational facilities, higher graduation rates, all of these things which are correlated with the health of their population. if those entities are really so important in determining healthiness.
Well, I mean, actually, that's something that goes on today. Health plans are providing financial incentives to their beneficiaries to exercise and to agree to participate in disease management programs. So we are experimenting with financial incentives to enrollees, and also, and this has been quite controversial, but employers are also creating incentives, or in some cases, I guess we could call them penalties, to the employees for smoking, or for not agreeing to an annual physical exam. So these things are going on. I'm not really an expert on that, so I won't comment on sort of the state of the evidence. I guess what I've seen on a casual basis is that sometimes it seems to work and sometimes it doesn't. And I think some of the same concerns that I raised about monetizing quality of care, assigning, sort of financial incentives to certain activities that people might undertake because there's a certain intrinsic motivation for it anyways, and how does that potentially devalue it? There's probably some similar concerns that may also apply to individuals who are given financial incentives to take care of themselves. But I mean, this is something that goes on, and Blue Cross Blue Shield.
Yeah, we're experimenting. I mean, we're all experimenting now with behavioral economics, and some of the things that we thought might work turned out, not to. And there have been conversations about, should you make maintenance medication for folks with chronic diseases free, and would that help with medication adherence? And actually, the results are kind of mixed. Surprisingly, I was a big fan of that idea, actually. But I'll tell you, I'm a Blue Cross, big surprise, I work at Blue Cross, I'm a Blue Cross member, and I have a $600 financial incentive in my plan that is tied to a whole series of health goals, including, getting a personal health assessment and exercising and setting out personalized, improvement measures, and I think we're all really trying to figure out what works, because you look at me and I'm probably not the target for that, because even before this I already ran 4 miles a day, and I'm not the target audience. So I think we're trying to figure out that when we think about who's the target for some of these things, what's really motivating? Is it money? Is there other kinds of support people need? And I think we're experimenting. We don't really know the answer. And I think your bigger point about, and I'm looking at John when I say this, I think unfortunately both in Massachusetts and around the country, public health budgets have been just decimated through the recession. And it's going to take a long time to really claw those back. But I think we absolutely have to. Because I think there are so many issues that are it's really only public health interventions that are going to get at. We're not going to get at it just through the services that are covered in health insurance and through the medical care system. So I'm hopeful we'll all be voices and advocates for that.
A few years ago, there was a comparison of two communities. One was McAllen, Texas, and the other was Grand Junction, Colorado.
Tulgawande, yeah.
With McAllen providing the worst outcomes at the highest cost, and Grand Junction providing the best outcomes at the lowest cost. Wonder what your take is on the Grand Junction case. What are the lessons to be learned from that?
There is a lot of variation in cost and quality across the country. We always understand it as well as we would hope to. That was sort of a high-profile situation. Actually, the study's going way back, going back to the early 1970s, and pretty much demonstrating the same thing. You go to, across different communities, sometimes communities that are fairly close to one another geographically, and you'll see dramatic variability in terms of cost and quality. And, it's not always readily understandable, but we want to be able to increasingly sort of get a better handle on what's driving that variability, that variation, and use it to sort of establish best practice standards that can lift cost and that can lift efficiency and quality, everywhere. But you really see those dramatic, patterns of variation. And again, it's not necessarily in two disparate parts of the country. There's studies showing that you can look at New Haven and Boston and see some pretty dramatic patterns of variation as well.
Yeah, I'm not enough an expert on Grand Junction to tell you whether I think Grand Junction is the ideal we're all aiming for. So I think that's part of this equation too, is actually really trying to get at, what is the model, what is the ideal delivery system, because I venture to say everybody has room for improvement in the U.S. Sadly.
I mean, it's true though that some of what they found is it's just the local culture.
Yeah.
It's the norms that the physicians operate under. I mean, Winberg's found this, he's from Dartmouth, that it's just the norms in a community. If the physicians are used to referring to their buddies and their buddies, are high cost, well, they're not going to think about cost. They're just going to refer to their physician buddies.
And to extend the norms become also community patient norms.
Mm-hmm.
If you live in a community where if your friend went in for the same thing and got referred for an X-ray, you probably, it creates a norm in a community where you feel like if you don't get referred for one too, that's a problem. So I mean, these things can also become kind of self-perpetuating in terms of expectations. So.
Well, my recollection was, in the case of Grand Junction, that their outcomes
are better.
10 years beforehand or something or other were pretty horrible.
Yeah.
And they got together and said, we've got to do something better. And I'm not sure what it was.
Yeah. And there are really great examples around the country of providers who are making incredible progress, and they range from safety net providers, providers who have really large portions of low-income populations. I'm thinking about Denver Children's Hospital to, there's actually there are a couple of hospitals in the country, including one out on the West Coast, that has been working on systems improvement and done such a great job at it. I'm thinking about Virginia Mason. But they've actually created so many people, physician leaders from places like Boston were flying out to see what they did. They actually created a consulting company within the hospital just to manage the demand for people coming out to fly and see, what was their special sauce. So there are community-based initiatives and just individual systems to look at, where there are a lot of examples that we can, apply in other places.
We have a very large and extremely diverse healthcare system across the country. And I think President Obama will throw out Mayo Clinic, I think, is sort of a benchmark. But anyone who's been to Mayo Clinic will tell you that is not an easily replicable model.
Yeah.
I mean, it is very different. It's grown up over an extended period of time. They have a distinct culture. Certain providers gravitate there, and you can't just, reinvent that in other parts of the country overnight. So we have a very large, very diverse healthcare system. There's certainly communities, there's certainly organizations that really are making a difference and improving quality and improving efficiency, but they're not easily what that secret sauce isn't always readily available and can't always be sort of manufactured somewhere else.
And I'd say some of it's a leadership interest in change. The forces that are invested in the status quo are pretty powerful. So to overcome them, in any one institution, really requires a real visionary and forceful leader. I mean, to be pretty blunt, I think if you look at the case study examples, whether they're community-based initiatives or specific hospital or physician group initiatives, it takes a really strong leadership vision in this environment to drive that change. And unfortunately, we still have a lot of parts of the system that, they feel like things are going fine right now, despite all the data and evidence to the contrary. I mean, to be blunt about it. You agree?
Agree.
Yeah.
Okay, one more question. We'll take from the back.
How do you think health plans, hospitals, med schools should deal with the need of improvement on the cultural competency field? How relevant do you think cultural competency is in regards to the new payment methodology? And is there any way to link financial results to being cultural competent?
That's 3 questions, by the way. Tate, why don't you just pick one?
I'll answer it. I mean, I'll say our patient experience measures are actually a way of incorporating cultural competence. I mean, you couldn't do well on patient experience if you weren't a provider or organization that actually was responsive to the different cultural needs of the patient patient population that you're serving, but I think it's a huge issue and one that needs more attention and more support in the healthcare system right now. And it's it's been one that I know a lot of you around this room have been working on for a long time, and figuring out how to get the resources to actually really provide culturally relevant care continues to be a challenge. But it's going to be critical to being able to achieve the system that we want.
Okay, well, join me again in